Core to the strategic approach and therefore to our work was the management of CVD as a family of diseases. So the work of the NCVIN is really broad, and it includes, for example, coronary heart disease, stroke, hypertension, diabetes, kidney disease, high cholesterol. We've got a really broad remit. And if you look to slide 4, this represents our 3 core work streams. So intelligence into practice, which really focuses on the translation of data and intelligence, improving awareness and understanding of data and how to use it, for example, through our program of masterclass that some of you may have attended. Tools and resources, you'll see a few examples of these today. So, for example, our profiles and primary care intelligence packs, which really present robust and comparable data that can be used locally to identify problems and priorities in relation to CVD, think about variation, measure improvements, and so forth. And finally, a research and development work stream where we really support the continuation of national audits and registries, thinking about robust data, data linkage, and try to support research that really strengthens the evidence base for cardiovascular improvements. And so I'm going to hand over to James, who's going to begin taking you through some of our products and tools.
Hello everybody, I hope you can hear me. I'm James Hollinshead. I'm one of the analysts who works in the NCVIN, and there are I particularly work on kidney disease, so forgive me, I'll be showing a few kidney disease examples, but we equally have analysts who work on the other disease areas that Rachel mentioned previously. And this slide which we're on now, which is slide 5, we're going to talk through some of the tools and products that we have available in relation to this slide, because this slide's an example of the kidney disease pathway, but equally it could be any of the cardiovascular diseases such as diabetes or CHD. And on the left-hand side, which we've labelled the public health side, we're looking at people who don't have a disease at the moment, but who are at risk of developing CVD, and there's lots of tools that can help us assess the need for primary prevention by highlighting the scale of behavioural and non-behavioural risk factors for CVD. And in the middle of the pathway, the bit that's labelled primary care, this relates to people who have a diagnosis of cardiovascular disease, and these people are generally managed in primary care, where early diagnosis and management can help reduce the progression of the disease. And again, there's tools that can help us look at how well people are managed in primary care. On the right-hand side of the pathway, this looks at people with advanced cardiovascular disease, and again, there are tools and resources out there which can help us understand the morbidity and the kind of complex care that's associated with this secondary care end of the pathway. And just to put the whole pathway into context, in the East Midlands, where I work, there's around 200,000 people who are diagnosed with moderate to severe chronic kidney disease, which is in the middle of the pathway, and on the right-hand side, there's about 4,000 people receiving renal replacement therapy, and it's not unusual for any of the cardiovascular diseases to have this this relationship between a high number of diagnoses and a high level of activity in primary care compared to secondary care. So we're just going to move on to slide 6, because the next 2 slides we're going to look at tools and information which refer to this left-hand side of the pathway. So on slide 7, we're now starting to look at some tools or information that give us information about risk factors, whether they be behavioural or non-behavioural risk factors for CVD. And CVD is associated, as we know, with demographic factors such as age, ethnicity, and other wider health determinants such as deprivation. And this type of information can be found either at local authority level in the Public Health England health profiles, and at smaller levels such as ward level in the Public Health England local health tool. And the screenshots of those 2 tools on this slide. There's been a previous webinar on these types of tools, and that was called how you can use these tools to build a business case for CVD prevention programs. So I won't dwell on it anymore, but if you want to listen to that webinar, there's a link at the bottom of the page. So moving on to slide 8, we're now starting to look at some of the behavioural or modifiable risk factors for CVD. And again, there's a number of information sources available. And this slide just shows 2 profiles which are relevant to CVD, the tobacco and the physical activity profiles. The profiles are available at local authority level, and they can be found on the PHE profiles pages, which we sometimes call the PHE fingertips web pages. And I'm just going to mention this in a bit of detail because the Fingertips platform allows you to look at indicators in a number of different ways. So you could look at them graphically in spline charts or RAG charts, or you can look at them more simply, such as on the right-hand side, you can look at data points over time. But you can also use the platform to compare your area against a number of others, such as similar local authorities or other local authorities within the region. You can also then download your own information, create your own charts, and some of our products as NCVIN can be found on this platform, the PHE Fingertips platform. So moving on to the next slide, which is slide 9 for everybody on the phone. We're just moving a bit further along the disease pathway now, onto the kind of tools which can help you describe how well people are diagnosed with cardiovascular disease and how well they're managed in primary care. So slide 10 is where we're heading now, and this slide is all about prevalence, so all about people who have developed cardiovascular disease. So because some cardiovascular disease, such as hypertension, diabetes, is asymptomatic, there are some people who don't know they have the condition and are therefore not known to their GP or recorded on GP disease registers. And if you do have a disease and you're not on a GP register, you're less likely to receive treatment which may help reduce the progression of your disease. And it's we know how many people are recorded on GP registers because we have something called the Quality and Outcomes Framework, which is a system which is used to monitor GP activity. But we can also estimate the number of people who may not be on the register, so we can estimate how many people may be undiagnosed in the population. And this value is called the expected value. The number of people who are recorded is called the observed value. And so, for example, in this practice, we have black stick men and yellow stick men. The black stick men are the ones who are recorded and are on a GP register, and the yellow stick men are the ones who are undiagnosed. And you may see from this example there may be 200 people, there's 300 people who are diagnosed and a further 200 people who may not be diagnosed. And then we can make something called the observed to expected ratio, and in this case it's 3 divided by 5, which is 60%. So in this particular example, there is the potential for this practice to improve case finding and identify more people with the condition. So the NCVIN has produced a number of these what we call prevalence models to allow us to estimate the undiagnosed population within an area, and we've produced with our partners models for atrial fibrillation, diabetes, chronic kidney disease, and hypertension. So if we go on to the next slide, which would be slide 11, NCVIN have produced some tools which can help you to estimate the number of people who within your area who are undiagnosed. These slides are taken from something called the NCVIN CVD intelligence pack, which there's a link to at the bottom of the page. And these slides, it shows the proportion of people who are diagnosed with hypertension compared to the total number of people who may have hypertension in CCG. That includes diagnosed and undiagnosed people. And this example, which is Bradford CCG, on the left-hand side of the slide, just over half, or 56% of the people who are estimated to have high blood pressure are diagnosed and on the register. And we can estimate from that in Bradford there may be as many as 8,700 people who have undiagnosed hypertension in the CCG. And this is not uncommon. If you look at the left-hand side of the slide, the usual amount of ascertainment is about 60% at CCG level. The right-hand side of the slide shows this type of information at GP practice level. And looking at it at that low level can help you sort of answer the question which practices are doing well or which ones perhaps improve. And there's a large variability in the observed to expected ratio at practice level, in this case between 10 and 90%. And there'll be reasons for that that you will know locally. For example, the ones at the bottom with a low case ascertainment might be university practices where you'd expect there to be less people with hypertension. So moving on to the next slide, which is slide 12. Once people are diagnosed and placed on the GP register, what kind of information do we have about how well they're managed in primary care? much of the information comes from the Quality and Outcomes framework, and there are several tools which help you to look at that information in depth. So on the right-hand side of this slide, there's another picture from the CVD intelligence packs, and it shows QoF information at CCG, STP and GP level. The packs are quite useful because they also start to quantify the potential benefits of improving care. So in this example, it shows the number of people with atrial fibrillation who may benefit from a particular treatment called anticoagulation, which helps to reduce the risk of stroke. And in this CCG, roughly 3,200 people are identified with atrial fibrillation, and about 2,200 of them are being anticoagulated, which means roughly there are 1,000 people who are eligible for the treatment who are not being anticoagulated. So on the left-hand side, you can look at something called the National General Practice Profiles, which is another Public Health England product. And this tool's useful because it allows you to look at a particular GP practice and look at several QoF measures in one time, just to help you unpick whether there's a practice that's doing particularly well or may need improvement in terms of their CVD management overall. So moving on to the next slide, which is slide 13. As well as highlighting variation in primary care, NCVIN's worked with partners to present the information in a way which might be able to help you promote quality improvements locally. So the examples on this slide are called the atrial fibrillation and the hypertension, how can we do better profiles. And there's a profile for each CCG, and they're about 2 to 3 pages long. And the first page contains information or data about how well the CCG is managing the condition in primary care, and the rest of the profile, the other 2 pages, provides information on how practice can be improved, and this is all based on evidence-based information and interventions. So it's a good place actually to look for how you can perhaps improve management of primary care. So if we go on to slide 14, we're now kind of moving over to the right-hand side of the disease pathway, to the more severe end, and obviously this has huge implications for people's well-being. So for example, in this case we're looking at kidney disease, and some people with advanced kidney disease may require dialysis, which means you need to go to hospital or need to go to a unit 3 or 4 times a week to receive treatment. So it's obviously very debilitating for people. And if you move to slide 15, the NCVIN does produce information on this kind of side of the pathway of people with advanced disease, and it's usually in conjunction with the CVD audits, which you can see listed on the right-hand side of this slide. The other example on the left-hand side is something called the diabetes foot care profiles, which highlights variation in amputation rates or hospital episodes for diabetic foot care. And I won't dwell on that because John's going to talk about this profile in a bit more detail in a moment. So moving on to slide 16. We've been through the whole of this CVD pathway from the left to the right, from public health to the secondary care end, and highlighted a number of products, but you may not have time to go and look at all these individually. So there are some products which help to bring this type of information together. And if you want somewhere to go for a quick overview, the next few slides might show you the best place to go for this. So if we go on to slide 17, the first product I'll highlight is something called the Size of the Prize, which is a CVD prevention product. And for each sustainability and transformation partnership, there's information presented on the potential benefits of CVD prevention. So this fact sheet, for example, shows the number of people who are undiagnosed with atrial fibrillation and hypertension, and it goes on to quantify the potential benefits of improved management of both these conditions in terms of events avoided and potential financial savings. And if we go to slide 18, this is a similar type of approach taken for health checks. And so for each STP area, it highlights the potential benefits of the health check program. So as well as looking at the activity of the health checks program on the left-hand side, it then starts to estimate perhaps the number of new cases of disease that may be identified, and the number of possible new prescriptions for high blood pressure and high cholesterol. So if we go on to slide 19, NHS Right Care is one of the partners that's represented within the NCVIN, and they also produce intelligence products that bring together information from all parts of the CVD pathway. And this is an example of one of their pathways on a page. And for each CCG, Right Care produce pathways on a page for all the CVD areas, so stroke, diabetes, kidney disease, and heart disease. And they're fairly logical, actually. If you look at the left-hand side of the slide, it shows some indicators from primary care, and on the right-hand side, it shows indicators from more advanced disease in secondary care. So again, they follow the pathway of care from left to right. And you can see where your CCG is an outlier compared to similar CCGs, depending on whether the bars are above or below the line, indicating better or worse, or higher or lower practice. So just moving on to slide 20. This is actually my last slide, but it's a very important product actually. This is something called the CVD Profiles, which is another tool which the NCVIN produces, and it does cover a wide range of cardiovascular disease information. And for each CCG, there is a cardiovascular disease profile for kidney disease, diabetes, CHD, and stroke, and they contain CCG level information and also STP level information. They all follow the pathway through care, and they come in two formats. The one on the left-hand side is an example of the 6-page report-based profile, which contains not only figures on CVD management, but also describes why the information is useful. But on the right-hand side, there is also a link to the interactive version, which again can be found on the PHE profiles pages and allows you to look at the information in the different formats that I described earlier. So these are actually perhaps the best place, or the first place to go if you need a quick overview of CVD in your area and you've only got a few minutes before a meeting, for example. So far we talked about what types of products are available, and now John is going to talk a bit more about how the tools can be used in practice.
Thanks, James. Yep, so moving on to slide 21. The idea is that by this point you've got a better understanding of what tools and products are out there around cardiovascular disease that the network produces. But of course what matters is not that they exist, but rather that they are useful and they can actually be used for informing commissioning, for informing needs assessment, driving up service quality, and ultimately having some sort of impact on improving public health when it comes to cardiovascular disease. So the intention of the next few slides is to suggest some ways, firstly in general, that the tools and products that we produce can be used, followed by a couple of real-world examples where the tools themselves, or at the very least the data that's contained within the tools, has been used in projects locally that have been successful in improving public health and outcomes. So moving on to slide 22, we've got a list of general things that the products and tools that we do and produce can be said to be useful for. So there's some commonalities between most of the tools that we produce, largely because the intended end user in most cases is commissioners, whether it's within CCGs or local authorities. So one of the first things that a lot of tools can help with is sort of raising questions and posing questions about what is going on locally. So we often say that the data is going to need local interpretation. It won't provide all the answers, but the tool can start to raise some of the questions that may be pertinent locally. For example, the intelligence packs present information on treatment targets for blood pressure, as James said, at sort of GP level as well as CCG level. You could have a look at the way we present the data, then easily highlight variation between practices. You would then need to locally interpret and say, well, why does this practice have a better attainment of treatment targets around blood pressure than this one? And there may be, as James suggested, sort of data anomaly or issues such as one's a university practice, the other one isn't, but maybe there is something to do with the treatment and care pathways in place there, and it could be a place to start looking. So a lot of the products highlight that sort of variation, and then it would be up to local areas to start to do a little bit more digging. A lot of the tools we do are useful in sort of informing decision making. So whether that's decision making about commissioning services or setting priorities, the CVD profiles may be a good place to start to look at that. Because we've got outcome data in there, treatment data, risk data, you could look at one disease area and see for a local area you're doing great in terms of diabetes, but perhaps people aren't thinking kidneys, and some of the kidney data may suggest outcomes and treatment might not be quite as good as it is for other areas, and decisions could start to be made based on this sort of high-level indications of variation. Driving up quality. So I'll not dwell on this too much because the next few examples sort of focus around quality, but it's perhaps worth saying that a lot of the data that we include in our profiles and tools comes from either the quality and outcomes framework or information shared with us from the national audit programs, both of which take treatment targets which are evidence-based and assess attainment against those. So it would follow that to reduce variation or improve the quality of these targets, you would have an evidence-based rationale for increasing cardiovascular disease or reducing cardiovascular disease locally. The next one, freeing up time for local intelligence services and analysts locally. So personally, I worked as an analyst in a local authority for a number of years, and one thing which was a huge burden was to do the joint strategic needs assessment every 3 years, and at a time when you had to produce a lot of the rates and the mortality rates, going to hospital sort of rates and all these sort of things, it could take up a lot of time, and at the end of sort of a large project such as doing a JSNA, you could sometimes question actually the impact it had locally. So hopefully the fact that at least for cardiovascular disease you have a place to go in terms of our products and tools which shares the methodology and things such as mortality rates and admission rates and prevalence and incidence rates all in one place, means that for perhaps writing the background section to JSNA chapters and such, a lot of that can be supported through our tools, meaning that you have more capacity to focus on locally pertinent issues around cardiovascular disease and intelligence projects which could be concerned as sort of quick wins, if you will. Next, monitoring and evaluating change. So again, the two examples that I'm going to give sort of highlight how our products can be used to do this. But again, I think the sort of ease of having it all in one place is a real sort of benefit of the tools that we produce. You could go and get all the QOF data and data yourself, but the fact that we put it in fingertips in a way that you can assess trends hopefully is useful for ensuring that you can evaluate change of any local programs through our tools. So, moving on to slide 23. We're going to discuss two main examples here of how the tools have been used in practice. One is diabetic foot care, which comes as an example from NHS Somerset, and the other is stroke reduction in Bradford. Now, just say, I'm not going to go into great detail about the interventions themselves, but rather how the data was used to inform and evaluate those interventions. So, if we get started on slide 24, this is an example which highlights how the tools can be used to inform, to monitor changes and evaluate system changes which have been put in place locally. It focuses on diabetic foot care, particularly the profiles that we produce, and we published an update to those last month, and work carried out in NHS improving their diabetic foot care pathway. So, for those that don't know, diabetic foot disease is a big issue and a huge issue in terms of a complication of diabetes. So people with diabetes are at an increased risk of peripheral arterial disease and neuropathy, which ulcers. Ultimately, that may need an intervention such as a minor or major amputation of a limb. There's about 25,000 such amputations take place every 3 years. It's costly to the NHS, to the patients, to quality of life and prognosis. So really is, although it's down the sort of secondary care end of the pathway, it is a population level and public health issue. We've produced profiles that look at the risk of having a major amputation, so how the risk differs between different demographic groups, how treatment targets are being met locally, and then how outcomes, particularly amputations relating to diabetic foot disease, differ between CCGs. So we've gone to great effort to control for age, ethnicity, sex, other non-modifiable risk factors factors, which means that if you could identify a high rate of major amputation in an area, there is good evidence to suggest that these rates are amenable and could be reduced through service changes. And that's exactly what NHS Somerset identified in 2011. So clinicians, commissioners, people across the system looked at their rates in the diabetic foot care profiles and realised they were significantly higher than England, higher than comparators. I think we've carried out over 100 lower limb amputations in 3 years. You know, they had a real sort of potential issue with a high major amputation rate in that local area. Over the next 6 years, they implemented a number of interventions to considerable cost and effort to the system, but it involved things such as streamlining the referral pathway between podiatry services and secondary care, closer working between primary, secondary and community care, improved IT systems, auditing of amputations, a whole host of time-consuming, cost-consuming interventions. What obviously was then important was to know that this effort and these interventions had improvements which could be measurable in terms of outcomes to cardiovascular disease. And that's exactly what the profiles provide a way of measuring through robust and consistent measures changes in the major amputation rates. Now, 6 years later, NHS Somerset could evidence that they'd almost halved the rate of major amputation rates. They went from being one of the worst performing areas in the country to one of the best performing, and significant changes statistically, even when you're taking into account the changes in the underlying population. So that's an example of how you can evidence changes in local areas through our products. I'd suggest there's perhaps even scope to do more. So we share data with the National Diabetes Audit, who provide us with data that we put onto our fingertips platform. So an important part of foot care management for people with diabetes is having an annual check. We include diabetes audit data in the fingertips platform, where you could see the variation between GPs, between areas, in terms of who is having these preventative foot care checks. So bringing it all together, you can implement a local program, assess the change, and also get ideas about where to start focusing the programs based on the data available in particular the foot care profile tool, but also on the fingertips website. So now moving on to slide 25, this is example number 2, and it focuses on the use of routine data, QOF data in particular, which you can find in our tools to improve the quality of services specific to stroke reduction. And it's a project in Bradford where the focus was on the treatment of atrial fibrillation through anticoagulation, and I think James sort of mentioned that as an area which is a good area to focus on in terms of reducing cardiovascular disease and outcomes through fairly quick winning sort of interventions. Now, I do need to give a little disclaimer here. We don't actually know if Bradford use our tools exactly to access the data, or they access the data through different methods, but the principles remain the same, that there are opportunities that the tools provide through the highlighting of treatment target attainment for these sort of interventions. And I've also spoke to Greg, who sort of oversaw the project, and he's happy for us to use this as an example, so it's all good. So there are two large stubborn issues when it comes to stroke prevention, namely the underdiagnosis and the undertreatment of atrial fibrillation. So AF is a heart rhythm disorder that increases the risk of stroke by about 5-fold. There was a good evidence-based treatment in the form of anticoagulation that is not without risk, but it's suitable for most patients. It reduces their risk of stroke by about 2/3. Importantly, in the quality and outcomes framework, there's a measure of the proportion of patients with AF who are at an increased risk of stroke who are treated appropriately with anticoagulation. So we've got a measurable, clear quality standard here that we can benchmark and use to assess any changes and sort of drive up service quality. So that's exactly what Bradford did. They looked at their rates of attainment against this particular treatment target, and so they wanted to have 70% of their suitable patients receiving anticoagulation. They did this through, or they attempt to do this through a range of interventions, not dissimilar to the sort of interventions that we saw in the foot care example, things such as training, practice visits, improved IT. From a data perspective, they made the data easily accessible, they highlighted the variation, and they fostered a sort of competition between different GP practices in increasing the rates of anticoagulation for suitable patients. At the end of 18 months into the project, they had 714 additional patients on warfarin. If the good evidence is to be believed in terms of what this means for outcomes, you can expect 29 fewer strokes and 17 deaths to have been prevented as a result of what is essentially a data-driven, low-cost intervention. And the important thing here is that this data, the same data that was used by NHS, by Bradford as a health system, is available in the intelligence packs, and we highlight variation between practice and could suggest places to start with similar interventions. Again, I think there's scope to do more than simply looking at the treatment of atrial fibrillation through anticoagulation. The other issue I mentioned was the underdiagnosis of atrial fibrillation, and the models that James spoke about, where we have expected versus observed, is something that, again, that we include in the intelligence packs, and you could use that to start highlighting where underdiagnosis of AF and undertreatment could be, and base a project or an intervention around trying to improve both of those quality standards. Moving on to slide 26. So this is sort of a bit of a summary slide in terms of where you can actually get these products, these tools, and all this data that we've been speaking about today, so how you could access that. And it's worth mentioning, if people haven't visited our websites for a while, they may notice that there is no longer a National Cardiovascular Intelligence Network website. We're now hosted on the .gov platform. So there's a link on the left-hand side of this slide which will take you to our .gov web presence. It's essentially a very long list of different products, different tools, and data analysis that we do. I think pretty much everything is covered there. The links may take you to external sources, but that would be a good place to start to access some of the data and tools we've spoken about today. Now, the other web presence that we have is on the Fingertips platform. Now, anything that we sort of badge as a profile sits there, so the cardiovascular disease profiles, the foot care profiles are all on there. The great advantage of the Fingertips platform is that it's not just static PDFs, although you can download the PDFs from there. There's also the opportunity to download the data into Excel to highlight changes over time. It highlights significant differences to benchmarks. If you've got a particularly advanced intelligence team locally, they can use programs to access something called an API and pull the data directly out into your own systems and start to automate the production of say, JSON-A chapters and such that way. So I think the Fingertips platform provides a greater scope and some more flexibility in accessing the data. And then our final slide, which is slide 27, again, it's just a list of places you can go to access the data, and just also a reminder that we have a newsletter which we publish quarterly with updates on all the sort of work we've been doing ourselves with partners and new publications. And if you'd be interested in receiving this sort of information on what's going on in the world of cardiovascular intelligence, then we'd encourage you to sign up by dropping us an email and just asking to be added to the newsletter. I think that's everything me and James wanted to cover for today, so I'll hand back over to Catherine, who'll manage just a Q&A session.
Thank you very much, John, James, and Rachel. That was a very insightful webinar, and had a wide range of resources produced by the NCVIN can be used to apply local needs in terms of cardiovascular disease prevention and management. I'm going to now stop the recording and invite the audience for questions. I'm going to first, people will be able to write questions using the instant messaging over Skype. And those over the phone, I would then come to you and ask you